Welcome to this webinar of the Lupus Hub, devoted to talk on what are the key considerations when managing comorbidities and infections in patients with lupus. I am Ricard Cervera from Barcelona, and I will be accompanied by several members of the Lupus Hub Steering Committee. And just recently, probably you are aware that were released the 2023 update of the EULAR recommendations for the management of systemic lupus erythematosus. They were presented at the last EULAR Congress in Milan, and just very recently, the final publication appeared in the Annals of the Rheumatic Diseases. And these updates include very interesting aspects, some changes from the previous recommendations regarding hydroxychloroquine, regarding the lowest dose of prednisone that could be recommended for maintenance, regarding the position of the biological therapies, including the new biological therapies in the management of lupus. Also, it includes the recommendations for the management of kidney involvement for lupus nephritis. But in addition to these recommendations, we have to take into consideration the management of the comorbidities. Nowadays, it's perfectly clear that the main target that we have to obtain in patients with lupus is to prevent organ damage. And organ damage in lupus depends on not only disease activity, not only the inflammatory manifestations due to lupus manifestations, but also the side effects of the drugs that we are using for the management of lupus, and last but not least, the comorbidities that accompany patients with lupus. And I think that it's important to take into considerations, to devote some time to discuss a little bit more on these comorbidities and the important role in the organ damage in patients with lupus. I think that both the previous 2019 EULAR recommendations and the current 2023 EULAR recommendations both have some specific parts, some specific recommendations devoted to comorbidities. And we can just have a look at these recommendations, and then to discuss a little bit more on this. And starting from the 2023, the last recommendations, there is recommendation number 12 that deals with the antiphospholipid syndrome, which is a very common comorbidity in patients with lupus. Around 20 to 30% of the patients with lupus present with this systemic autoimmune disease. And the recommendation states that lupus associated with thrombotic antiphospholipid syndrome should be managed with long-term vitamin K antagonist after the first arterial or unprovoked venous thrombotic event. And low-dose aspirin, 100 milligrams a day, should be considered in patients with lupus without manifestations of the antiphospholipid syndrome, but with high-risk antiphospholipid profile. Actually, this is probably a more specific recommendation than the previous recommendations that appeared in the 2019 updated recommendations. But probably we have to focus a little bit more on the following recommendation. Recommendation number 13 of the 2023 recommendations, which is that immunizations for the prevention of infections, including herpes zoster virus, human papillomavirus, influenza, COVID-19, and pneumococcal, the management of bone health, nephroprotection, and cardiovascular risk, and screening for malignancies should be performed. I think that we probably should focus a little bit more on these comorbidities that are not specific autoimmune diseases like the previous one, the antiphospholipid syndrome, and to see how do you address these different comorbidities in your clinical practice. I would like probably to know first from Mary, what is your opinion on addressing, in general, comorbidities in order to prevent organ damage in patients with lupus?
So, Ricard, thank you. I think, in terms of looking after patients with lupus, managing or preventing, so to speak, comorbidities has become an integral part of the management. And as a matter of fact, in many patients, it becomes the integral part of the management. So I think that we should really be looking at recognizing the comorbidities that can occur, investigating them appropriately, and then beginning early treatment. So if you just take the example, the comorbidity that we've all had the most experience with for a long time now is the cardiovascular disease, atherosclerotic vascular disease. There are many ways now that have demonstrated those patients who have subclinical cardiovascular disease. In other words, already have evidence of some involvement without clinical manifestations. And this is picked up either by intimomedial thickness of the carotid artery, by myocardial scanning, perfusion studies, etc. And so we should be looking for these subclinical forms of the disease early and then treating them. And then, of course, the part that unfortunately many doctors who look after lupus patients don't have time for is the treating the comorbidities early, such as hypercholesterolemia, hypertension, diabetes, etc. And that's why more and more lupus clinics are multi-specialty clinics, where a number of physicians are looking after patients with lupus. Is this useful? Oh my goodness, it's useful. If you take the cardiovascular story, it used to be that in any cohort, there was always somewhere between 10 and 15% of the patients that had cardiovascular disease. If you look at the cohorts that have been started since 2000, like the SLE cohort, our recent cohort that we separated off, the prevalence of cardiovascular disease has been reduced 3- or 4-fold. So there's a success story, and I think it should be the story, the underlying story for all of the comorbidities. If you investigate them and treat them early, you can actually minimize or prevent them. And so I think this is a very important topic. And if timing in looking after patients is a problem, establish relationships with multiple specialties so that somebody will pay heed to these comorbidities in addition to treating the active lupus, which is a big job in itself. So I think it's a very important area. I'm glad that EULAR has updated the recommendations. And I think that we all need to be very perceptive for these and keen to A, diagnose them early, and B, prevent them if possible.
Thank you, Mary. Really, it's of paramount importance to control all these comorbidities in addition to control disease activity and so on in order to prevent organ damage. But maybe one of the problems that we have on the management of lupus patients is the diversity according to the different countries and to the development of the different countries. And I would like to know, as we have members of this panel from different parts of the world, how this is feasible to perform in different parts of the world. Maybe Manuel Ugarte, you can explain us if this is feasible and how do you perform this in Latin America?
Thank you, Ricard. Well, I think there are some tests that are not easy to do here, for example, in cardiovascular diagnosis, but I think there are things that we can do. For example, I don't know, patients, we can send the patient to the cardiology, they can review them, they can check if the echocardiogram is okay or not. I think maybe we cannot do as much as we can nuclear medicine for them, but there are many things that we can do. And for example, I think immunization in Latin America is very, very good. Probably it's better with kids than with adults. I mean, our rates of immunization in kids is over 90-95% in almost every country. And when we started the vaccination with COVID-19, our rates rise really, really fast. The problem here was the vaccine was not available at the beginning, but when you have the vaccine, our rates increase really, really fast. So I think the problem in immunizations here, for example, is that we don't send the patients to the nurse or to primary care, and they do not receive the vaccine because that, for example, when we started with the COVID-19 vaccine, we see that many of our patients didn't have pneumococcal vaccines or things like that. So I think the problem not for comorbidities is not only the money. Probably it's that we don't are looking for that. We are thinking, oh, our patient has an active disease that is important, but we don't think we need to reduce morbidity in terms of on long-term impact. Probably we are not diagnosing as early as we can on comorbidities, but I think for this topic, the main problem is the awareness of the comorbidity more than the lack of access.
Thank you very much, Manuel. The experience from Latin America. Maybe Professor James Wei can give us the experience from Asia, from Taiwan, and from other Asian countries.
Yes, thank you. Thank you, Ricard. I'm James Wei from Taiwan. As a rheumatologist in Asia and also in Taiwan, I think I would like to point out two missing puzzles besides this slide. Of course, I agree for infection, for cardiovascular, for other comorbidity. I think one of the most important one that we're missing is osteoporosis and vitamin D deficiency. Comorbidity like vitamin D could be osteoporosis and also other vitamin D related. And we always educate patients to avoid sunshine, but we seldom encourage them to check vitamin D level. So which I'm doing here, although they need to pay by their own pocket to check the vitamin D level. And on the other side, we also very aggressively to check their BMD if the patient is menopause, to check the DEXA or even check other osteoporosis major, like bone marker. So the number one is the osteoporosis. And also the second one I want to point out is the psychosocial domain of the patient, because many of them are actually very depressive, or even some of them have very stress in their family support or social support. So I all agree with the guideline over here, but sometimes you need to pay more attention to the psychosocial part. That's it. Thank you.
Thank you very much, James. I think that probably this is this last aspect, this psychosocial aspect, is certainly missing on these recommendations, and I fully agree that they are really, really very important. They represent an important part of, or important burden of the comorbidity problem in patients with lupus, for sure. And how is the situation in the States? Because as Mario stressed, we need this multidisciplinary approach. Do you think that it is possible? Betty Diamond from the States?
Well, you know, I think one of the issues with the psychosocial concerns in this is how much of that is sort of a comorbidity of a chronic disease, and how much of that is the disease itself, and how much of that, you know, can you actually see happening in the brain as a consequence of lupus pathogenesis. That doesn't make it less important by any means. And it really does need to be dealt with. And we know that lupus patients tell us that cognitive impairment, for one, is one of the things that, at least in the US, lupus patients tell us that cognitive impairment is one of the three most debilitating to them features of their disease. One of the three aspects that most interferes with quality of life. And so it's absolutely crucial to deal with it. You know, I don't know whether we should be calling fatigue a comorbidity or an aspect of the disease also, but that's something else that we need to deal with a lot better than we do, and is something very distressing to lupus patients. And I'm not sure you call this a comorbidity, but this is something that's a consequence of the toxicities of our medication. You know, I think all the time about how many lupus patients are still dying of infection, and how little evidence there is that the disease itself is immunosuppressive. So I think that that's an area that we really need to pay more attention to and mitigate in some way.
Thank you very much, Betty, for these important comments. Probably fatigue could be considered both as a manifestation of lupus and a comorbidity, but anyway, this is probably the most common problem in patients with lupus. If you ask patients with lupus, they will say probably that the most important problem for them is not maybe lupus nephritis or anti-DNA antibodies or other problems, but just fatigue. So we have to take this problem really as a very important problem for our lupus patients. I would like just before finishing this webinar, probably to talk a little bit on the two vaccines that have been recently introduced, and this is the best way to prevent these comorbidities is by means of vaccination. And we have recently the COVID vaccine, and we have the herpes zoster vaccine that probably will be needed in our patients with lupus, especially after the introduction of new biological therapies. Do you recommend to every lupus patient or to just a subset of lupus patients vaccinations with these two new vaccines? What do you think, Betty?
So absolutely. And pneumococcal vaccine is very important, and I think that we neglect advising our lupus patients to get a pneumococcal vaccine. And, you know, the RSV vaccine is coming along, is out there. And I think that until we get less immunosuppressive therapies for lupus, we really need to mitigate the immunosuppression with as much vaccination, as much anticipation as we can. So I assume that this is true everywhere where the vaccines are available. We know that lots of our medications increase the incidence of zoster. We should certainly be protecting against that.
Thank you very much, Betty. And I think that we have to finish this webinar. It has been very clear that to manage these comorbidities, to prevent when it's possible such comorbidities is a very important role in the management of lupus in order to prevent organ damage. That certainly is the main goal, the main target that we have to reach in our lupus patients. Thank you very much for your contribution to this webinar.